接下来呢，我们有请来自我们泰国的一位专家啊，是 Prof.Dr.Bancha 教授。我简单介绍一下呢，我们Bancha教授呢是来自于我们泰国叫法政大学医学院，他是泰国的运动医学骨科学会的主席，东盟运动医学与关节学会的主席。所以他的专长呢是肩肘和我们膝关节的外科。下面呢，我们有请我们 Prof.Dr.Bancha 教授，他的题目是呢，Sealing the Meniscus from Repair-Reconstruction to HTO Welcome。
谢谢你，谢谢。早上好，谢谢大家。我叫周天才 ，Genius Joe， 天才是我的中国名字。
周天才
，Yeah， 天才。
很出名的。
So曼谷，我come from Bangkok, and today my wife also coming here to support me. 谢谢。So I'm talking about the saving the meniscus from repair, reconstruction to the HTO. Okay, I love meniscus, and thank you, Professor Chernchujit, for the very warm welcome. Yesterday we have the very nice dinner with the Hong Kong team and also the China team. So next year we have the meeting with Hong Kong, China, Macau.
This year.
This year, not next year. This year, October, right? It's 23rd to 25th October. This is the venue. I welcome everyone to Pattaya. Yeah, Pattaya is a very beautiful city, and welcome everyone to Pattaya. So please send your sub-abstract video information. We will support you, right? I'm talking about meniscus. Medial side, lateral side is totally different. So everyone know the anatomy of meniscus. Medial side fixed, lateral side mobile. Lateral side you have this hiatus, the popliteus. This area we should not repair. We should move it. We should let it free, right? This is the meniscus anatomy. So today we are talking about the meniscus complex. We're talking about ram root, horizontal, radial, and also bucket handle, and also meniscus transplantation. So the trend of meniscus surgery is coming from meniscectomy to the meniscus repair. So nowadays, I think everyone try to save the meniscus. Once you cut the meniscus, that's the end of the knee. Your cartilage will gone finally, and you get arthritic change very fast. So this is my position. I prefer to hang the leg down so I can go around the knee. It's easy. When you go to the back of the joint, many times you need to go to the back of the joint. First thing I want to focus is the magic point release. We published this paper. It helped a lot when you do the meniscus bucket handle, root, ram repair. So it's worked very well. Yeah, and we can increase the joint space. So you draw the line from the posterior cortex to adductor tubercle. Draw the joint line. It's about 1.2 centimeters from the joint line. So I'm showing you this is a magic point. So it makes the joint open easily, and don't worry, the meniscus, the healing of the MCL is very good. You see that? The joint space is increasing, yeah, very much. And don't worry, the healing is very good, yeah. So there's many kinds of meniscus repair, you know, inside out, outside in, or inside, right? So I will not focus about this. I'm talking about the complicated meniscus. Root and ram, this is very common. We miss it a lot in the past because it's located in the back of the joint. So this is a hidden lesion, right? So this is left-hand side is a root, this is a ram lesion. So the clinical side is sometimes the same. The patient have pain on the medial joint line, okay? But the clinical presentation is different. So from the literature, if you have the torn ram lesion, the anterior drawer will be too much. We call this the phenociatic side. When you make a drawer test, you can feel the click and the patient have so much pain. Okay, this is the pathognomonic side of the meniscus ram lesion. Root lesion, common miss in the past. Patient come to see you like middle-aged patient, minor injury, twist, squatting. It's common, especially in China, we squat a lot, right? And this can be the torn meniscus, and the MRI look like this. You can see extrusion, ghost sign, also the cleft sign. So this is very common, like this. And many times in the past, the radiologists miss because sometimes it's not that obvious, okay? And you look at the specific side, you can see the bruise on the tibial side. You can see the small tear in the back like this. Don't miss it. Okay. So the root and ram is different. The root is always in the middle age, like Patrick, 50 years old. You can have root, not ram. Ram is young, like 30 years. The root is about 50, 60, right? It's different. The age different. Root is common, like minor injury, like squat in the toilet or miss the step. But the ram lesion common with ACL is totally different. Okay, and this is the classification from Laplace. Most common is a type 2. Okay, also the common association, as I told you, the root common association with cartilage, but ram associated with the ACL injury. So it's different. So if you have ram lesion, you have more anterior translation, also more external rotation. For the root tear, if it's torn, that means you loss of the hoop tension. It's like you have no meniscus, like you do total meniscectomy. That why it's very serious for me. The root patient, I will make a fast queue for the patient. The time is only 3 months. 3 months, more than 3 months, the cartilage start to degenerate. And if you repair the root after 3 months, outcome is not good. Okay, so this is our technique proposed in the arthroscopy. It's very simple. You make a tunnel and you use a meniscus needle. Okay, drop and make a posterior portal. Make it like this, Mason Allen's, right? Using very simple meniscus nitinol needle. Okay, and this is our literature transtibial. Once the meniscus root torn, it start to extrude. And if you just repair, sometimes not enough. You need to do the extrusion reduction, okay, like this one, right? We repair the root together with extrusion reduction. The meniscus will reduce into the joint, okay, using the small anchor. So once you have patient come too long, like the patient to see you like 6 months, 2 years, the joint space start narrow. Root repair doesn't work. You need to collect the axis. So once you have joint space narrowing, so every time you have root, you need to do X-ray standing view. If you start to have joint space narrow and malalignment, you need HTO. Okay, so this is a 60 years old patient. He's very active. He's marathon runner, and he heard the pop sound. The pop sound in the older patient is not ACL, it's root, but pop is a bit lighter. But ACL pop is really loud, right? The root pop is lighter in my practice. So first you make a magic point release. So I prefer to use the anchor. I make a nice reductions. This is my tunnel. And I prefer to use the anchor. This is a soft anchors, right? We publish this technique. Using soft anchor, the good thing is that you have short tunnel. So when you repair the meniscus, it's like you have no bungee effect. If you make a tunnel, long tunnel, you get bungee. So and then I back up with the button, okay? So you have like double row fixation, like rotator cuff, and the patient have good outcome. I feel like if I do the root with anchor and button, double fixation, outcome is better, yeah. So this patient have the meniscus root, but he come too late, you see? Cartilage is not so nice, so I repair the root, okay? And together with the high tibial osteotomy, okay? Root only not enough. Once you have cartilage damage, joint space narrow, meniscus extrusion, you need HTO, okay? So ram lesion, I told you, ram lesion common with ACL, okay? So the best view to look at the lab is to look the scope from the lateral, from the posterolateral, from the notch. You cannot see very well. This is a bad view, 30-degree scope from the notch. This is 70-degree scope. This is the scope from posterolateral. We published this technique, the transeptal ram repair. We're looking from the opposite side, like we do PCL. See? We look in the joint, this is ram. Cannot see well, right, from this view. So I break the septum and look the scope from the posterior compartment. And then you can repair your meniscus like you repair Bancha. You see that? I did not tell you, this is look like Bancha surgery, right? It's look like that. We're looking from the lateral. So I propose you to repair the ram from opposite side. You just need 30-degree scope, no need 70-degree scope, right? Like this way. And then you tie the knot, okay, like that. Very simple, okay? So this is my way of ram repair. So for the radial tear, nowadays, we know that radial tear is same like root tear because you lost of hook tension. For me, radial tear, I hate it. I don't like. The outcome is not good. I'm not sure about how about you, Patrick. I don't like radial tear because it's bad. Outcome is bad. So nowadays we make promote the healing by using the tunnel, and also we make a peripheral, and so the central part we repair it into the tunnel like Labrador way. Okay, and the outcome is better, right? But anyway, not so good comparing to the meniscus lamb lesion. Lamb is very good. So this is horizontal cleavage. Okay, many patients have no symptom, but once the patient have the cyst, the symptom will be bad, right? This patient have cyst. You see that the cyst is make a joint line pain. So the way to do that is first you cleaning. Okay, the meniscus make horizontal cleavage repair like this. I make microfracture, and also I put the marrow cells, we call this BMAC, into the meniscus. And we found that the outcome is better. You look at the MRI, this is before and this is after the surgery. You see, meniscus healing is so good. It looks like normal meniscus. This is the horizontal cleavage. I recommend you to make microfracture and BMAC injection. Okay, so this example of the ram lesion, we always start with ACL tunnel first and then go to the back of the joint. So nowadays I make 2 bites. Okay, I make first bite here and second bite from the joint. So if you make 2 bites, you have a bigger bite. Previously I make only 1 bite, but once you have 2 bites, you can get a very big circle. Okay, like this, and then after that you pass a graft ACL. For me, the ram lesion with ACL 100% healing. Yeah, this is true. The healing is very good. Okay, ACL with the meniscus ram lesion. Yeah, so this patient is 6 months after that, he's very strong and come back to sport. Okay, and it's healing. So this is the bucket handle lateral side. I think this is the most difficult for me because lateral side you have vascular supply, right? You have peroneal nerve, you have artery. So for me nowadays, I go to the back of the joint for bucket handle lateral. I try not to repair from the front. So I pat my scope to the back of the joint and I repair my bucket handle right lamb repair. Same, you see that? If you look from here, it looks like ram lesion, right? And you repair it from the back of the joint. So you have no worry about the vessels because you make all inside repair from the back of the joint. Okay, like this. Okay, and you have the very nice circumferential repair. If you repair from the front, I worry about the vessels. I worry about the peroneal nerve in the back, right? So the lateral side, you know that it's not like medial. For me, lateral meniscus repair is not easy. You cannot open the joint like medial side. You can make pie crusting or magic point release. This is the lateral side, right? And then I go to the front, okay, to make some more repair like this, okay? So I can save her meniscus. Even you have bad, yes, chronic meniscus tear, okay? And finally, she has good outcome, right? So for the bucket handle, like this patient have bilateral, medial side, lateral side bucket handle tear. So like this, you have double PCL side for the medial side, you have double ACL side for the lateral side. So for me, the concept is that like you close the zip, you're starting from the apex, right? You can start like this. Previously, I repair it like this way. I repair inside out for the body and all inside for the posterior part. Once the patient have chronic meniscus, I always make an open release of the joint. And when the patients have deformed meniscus, I will make Mason Allen. That will have better compression effect. You see this? Meniscus come to be like wedge shape, right? In the chronic meniscus surgery. So in meniscus, this patient in the past I cut it, but he's very young. You see that? This bad meniscus. So I try to save it. Once you open the joint, I make all inside repair. Okay, and also we inject the BMAX, also marrow stimulation. Okay, so in the past, I think I cut it, but nowadays I try to save it. And he has a good outcome after the repair. You look at the beginning and you look at the after repair, right? So this is a complex tear. It's horizontal with longitudinal, right? So after that, we inject the BMAX into the tear site, right? And the patient have the better meniscal outcome. So for me nowadays, I try to use less anchors for meniscus repair. I prefer to use all inside. You look at the meniscus, it looks much better comparing. So I like this way, but I like circumferential repair. Okay. So this is the bi-compartment bucket handle repair. Okay, very bad meniscus. He come very late. He come like 2 years after bucket handle tear. Okay, we try to save. This is medial side. Yeah, and this is the lateral side. Yeah. So finally we can save his meniscus. Also has a ACL also, right? Yeah, that like that way. Yeah. So finally we can save both meniscus, medial and lateral. And the patient have good outcome after that. This is ACL. Okay, so this is him after the surgery. So this patient have revision bucket handle. He's very young. That is, you see, there's a suture that is revision bucket handle. Okay, for him. He's only 19 years old, right? I try to save his meniscus like that. Okay, and yeah, finally he's have good outcome and become a soldier. Yeah. So this way, nowadays I change my meniscus repair. I don't like to repair the meniscus to the capsule. Now I repair the meniscus to the meniscus. We call meniscal base, right? Like this bucket handle. Because I found that when we repair the meniscus to the capsule, there's some extrusion. So nowadays we try to repair the meniscus to the rest of the meniscus like this. Right, without anchors, okay, and we found that the patient have less extrusion, and I use this concept for my meniscus transplantation. So we just start meniscus transplantation in Thailand because previously we have no allograft. Okay, we did not use the bone because when you use bone, you need to make an open incision. We use this way. Okay, we use all inside meniscus repair. First, you make a tunnel like you do root. This is posterior root. You repair the suture into the meniscus first, like this. Okay, I make like 10 sutures on the peripheral side, this way. Okay, you see that? And then I put this suture on the medial side, like this way. Okay, and then I make an anterior root tunnel and pass a graft like you do SCR. Okay. Pass the graft in like this is anterior root, that is posterior root. Okay, and then you repair the meniscus to the meniscus. So this is the same concept like bucket handle. Okay, and then you repair it to the capsule. And we found that the extrusion of the meniscus is less comparing to the previous technique. You see that this is meniscus repaired to the meniscus. But the key point is that you need to have very precise measurement. I mean the size of the meniscus. And after the surgery, the patient start to land motion about 2 weeks after the surgery. And you can see the nice healing of the meniscus after the transplantation. So in conclusions, for my meniscus repair, I try to save it as much as I can. Okay, so try to save your meniscus, don't cut it. Okay, and you need to discuss with the patient that you have good willing to save the meniscus. But if it's failed, don't blame me, don't sue me because I have good willing. Okay, if you cut meniscus, it's easy, patient happy, but that's the end of the knee. So for the root and ram, you try not to miss it because this is hidden lesion. Bucket handle is if you save it, I think the outcome is pretty good. For me, a bucket handle outcome is pretty good, but you need to have good space. Don't forget the magic point. Read my articles, magic point release. Okay, and that will improve the joint visualization. And for meniscus transplantation, I think that's new things. The concept is simple like bucket handle. Okay, try your best. But don't forget to look at the axis of the knee joint. If the patient starts up joint space narrow, axis deviation, you need to do the HTO before the meniscus surgery. And we have the workshop in this year meeting, also pre-congress, robotic surgery. This is trauma workshop. Yeah, it's it's a workshop in the hotel by the beach. The first time we did that in Thailand, by the beach. It is the complicated trauma. So please take this picture, scan the QR code, and come to Thailand. We have the second workshop, robotic surgery. Okay, this is the total knee, total hip using robotic. Okay, And the last workshop is for sport. This is shoulder instability surgery. Take the picture. Okay, and welcome to Thailand. 谢谢你们。